So next, I'd like to have Dr. NAMRATA talk on how a difficult cataract can be managed using the femtosecond laser. So ma'am shall be talking on femtosecond laser as an aid in posterior polar cataracts.
So thank you, Swapna. Thank you for making me a part of this course. Always a pleasure to be a part of your course. And I would be talking about flex in posterior polar cataract. There are no financial interest in any of the products mentioned in the presentation. And we all are aware that posterior polar cataract can be a really tricky situation, which could be open or which could be otherwise. And imaging helps in these cases because we have both IOCT as well as flax. So what we try to do is do flax and then get them to IOCT. But this is just to show that on the intraop OCT itself, you can see that that was a posterior subcapsular cataract, and this is a pseudo PCR because you can actually see that the PC intact is still there. However, this very clearly is actually a posterior polar cataract because one can also see that there is a gap which is present, and this on the table only it becomes visible, so it becomes easier for the surgeon to proceed with plan the case. Now this is again a posterior polar cataract, but then this posterior capsular dehiscence or posterior capsular tear is present right at one of the eccentrically, not that central, a rare thing to see. And then after you've done hydro procedures, hydro delineation specifically, as you come down, do your nuclear emulsification and cortical aspiration, you have to keep putting viscoelastic so that there is no vitreous which comes from that area, and the margins are quite well defined. And then with the opacity such as this or with the rent such as this, one can very easily put an intraocular lens in the bag. So that is not a struggle. In this case, of course, the optic capture was also done. So trypan blue staining is being done, anterior rexis is done, followed by the hydro procedures, and one can keep seeing what is the status of the PC with the help of the intraop OCT microscope in these cases. And subsequently, the posterior posterior capsular rexis is also done, which is being shown here. And then classically for these cases, we try to do optic capture. And when you do optic capture, you can actually see that the thing is going to be really stretched. You can actually see the spindle on the intraop OCT here. So we have various types of PPCs that are available, and we've described also various morphologies of the PPCs. And this is a case of flax in the posterior polar cataract. What we like to do is we either like to do 3 semicircles or do 3 semicircles with chops, because that creates blocks, and each of these blocks can then be removed. So this is the capsular rexis, which has already been done using the flax procedure. We use Lensex system, and then subsequently the chops are already there, so not much of stress you have to give on to the posterior capsule, which may or may not be open, and it forms into blocks. So these are just blocks, are just each of the blocks are just then eaten away, which becomes quite simple because there is no stress on the zonular bag or on the opened area. Of course, in this case it was not in this case you can see that there is viscoelastic is being instilled just before the cortical aspiration, and after doing the cortical aspiration, the intraocular lens is then being put. This is a 3-piece lens which is put here, and subsequently the optic capture is done through the area of the defect that is present. And in the large rent, if it is present, then in these cases one can even do a reverse optic capture. And this is a case in which the large rent is present after the, in a case of posterior polar cataract, where the reverse capture is being done. So what we've described is the 2 types of ways in which the chops can be done. The one is the cylindrical chops, which were cylinders which were made by Dr. Vasavada's group, and we added spokes, 6 spokes to it. So the advantage of those is that you just get n blocks, and each of the blocks can then be removed. So it is femtosecond laser, and I think both intraop OCT, it does optimize your outcomes because it helps you to dynamically look at the posterior polar cataract, and it is important to, it makes it a lot safer. It is not that you cannot do it. You can do it even without femtosecond laser, and for a surgeon who's experienced, probably it will not make too much of a difference. But I think for a novice surgeon or for a surgeon who's learning these cylinders which have been previously created, or the blocks which have been previously created, will make a lot of difference in the nuclear aspiration, nuclear emulsification and the aspiration. So thank you very much for your attention.
Is there any hindrance by the air bubbles that are formed during the laser process when this happens, or should there be caution? How does it go?
So regarding the, I think one has to be careful because there you are not doing hydrodelineation, it is actually femtodelineation which is occurring. And that itself helps because you don't have to do too much of, don't have to put too much of fluid there. But yes, air bubbles can cause hindrance, and that is something which one has to be careful about.
And Dr. Shreyas, have you had any practical problems when you have used the femtosecond during posterior polar cataract?
With the LensX platform, as Madam and TTL sir have described, the femtodelineation is a wonderful tool, and you can actually do layer by layer removal. Of course, manual multiple hydrodelineation can also be done, but it is not always as repeatable. So that is a challenge, whereas this gives the correct plane for us to really go insert a cannula and do it. And fortunately, because the density of the nucleus is usually very less in these cases, the amount of bubbles which are generated are also less. Even with very lower energy settings and parameters, we are able to get that kind of delineation. The only thing is with the Catalyst platform, we don't have that concentric rings. So in those cases, I prefer not to do a softening and only do segments, that is sectants. So that helps in a way that you still have a very clear view of your plane, because if softening is done, sometimes it becomes difficult to do your subsequent hydrodelineation. The plane of cleavage of your air bubble becomes a difficulty. That's a practical challenge I've felt. So in, if I'm doing, I just do only sextants for PPC cases.
Any questions?
Rather, I do the opposite. I've been doing this for the softer PPCs. I do 500 micron dose. I make 4 on the quadrant, and then do 500 micron dose. I know the softening part cubes. And then, because those are not of the periphery. If you've got a good dilated pupil with the hydro dissection cannula, just go to the end of that and do you get a nice round, you have got 800 micron cushion. And then those are soft, you can just do a bimanual IA and remove those. You don't need to even do it. And even if you take the phaco tip, it acts as a big, suction machine sort of thing. Go there and you, with a spatula there, you can just feed it and go. I mean, that has been working. I mean, I've done almost like 40 PPCs. I'm still, I think I had rupture in 2. Initially, I used to do those and then try to modify it. And when we saw that the LensX has that round, so work something like that. You go to the midway and then go one more, push, so you get a nice, the cubes separate.
Thank you for the tip, sir. Yeah.
May I ask one question? Basically, for most of posterior polar cataracts, they are the soft cataracts, and I think complication occurs during the IEA. So I can't understand how like femto is going to help in that way, because most of your nucleus part is far away from that PCR. Number 2, in this IOCT makes sense because some PPC have pre-existing rents. So I'm doing quite a lot of I'm do like charitable work. So most of PPC we are getting large number also, and doing routinely what we call the hydro dissection, not delineation. So our experience is that most of time you are having the rent during the IA, not in the doing nucleus management. So what is your take on this?
Your
Madam?
opinion, ma'am, on that? Do you have?
So I think you're quite right. Most of the cases are soft cataracts, but then what we are essentially trying to do with the help of the femtosecond laser is create cylinders, create blocks, so that less stress is there on the capsular bag. The problems do occur during the irrigation aspiration. I agree, could not agree more with you on this. But it just helps to, for those cases which are not so soft, and for those cases which are very hard, and you don't even know that there's a posterior polar cataract there. Sometimes we've had situations like that also. So I think in those cases it really makes a difference. Flex really makes a difference. Even if you just do sextants for a hard cataract, which you don't know is a posterior polar and will turn out to be posterior polar, I think it makes a lot of difference for those cases. And also for cases which are moderately hard or not so soft, it makes a difference. Of course, like I said, for experienced surgeon, it probably will not make that much of a difference. You would get away with either ways, flax or no flax.
The-
Ma'am,
the-
my one fundamental
No, I agree with you completely.
whenever
That
the
irrigation aspiration you are saying is a more critical or a crucial time when
one
problems will occur.
One thing more, because the nucleus is far away from that defect, and most of time we are having the cortical plate in between. So
Yeah, so,
even if you are not having a femtosecond, if you are doing some SICS work, then you can manipulate that nucleus and take it later outside. So, but
definitely.
even intraoperative OCT is like quite helpful in this.
Yeah,
So in the flax, if you see, all of them do have a OCT image. We don't have a. I mean, I didn't put that here.
Yeah.
The image of the intraop OCT, but it is there. Although the resolution may not be that great,
Yeah.
but it is definitely there.
Other than the live OCT you're talking about,
Yeah.
the other inbuilt one. in the
Inbuilt
machine.
OCT in the flax machine also has a.
That is the advantage, real advantage.
I think Dr.
The
your group has
point
already
that
published, no?
yeah,
Gitansha has already published.
yeah, this thing and the fact I think we are all trying to stress here is when you do a hydrodelineation manually, we find that there is a lot of difficulty for beginners to take the rest of the epinuclear part out without disturbing the capsule. Whereas when you do making cylinders or wedges, there is so much of pneumodissection happening besides the passing of fluid. I mean, you don't need to pass as much fluid as would endanger the capsule. So it loosens up that quite a bit. I mean, even without passing fluid, you're sometimes able to rotate the whole thing. And so it is that nuclear aspect which is controlled by the femtosecond laser, definitely not the IA part. There you have to be careful. Even if your PC is not ruptured, a rough IA can cause it to rupture. But in cases where you cannot have a view, for example, in a mature cataract, would you recommend a B scan which might show a posterior capsular dehiscence?
So immersion scan possibly may show a posterior capsule dehiscence, but yeah, that is the way if you don't have a ASOCT to look at it.
So
Okay,
thank you, ma'am. Thank you very much for that comprehensive talk, which encompassed a lot of features regarding the posterior polar cataract.